Pete Grunewald. Got it. It's in progress. So I am the Director of Research at the Leonard Davis Institute and also the lead at Penn for this really great consortium that we've had, cooperative faculty exchange between ourselves at Penn, the IHPI at the University of Michigan, and the Institute for Health Policy at the University of California, San Francisco. It's sort of been a hostage exchange. We get some of their junior faculty for a period of time. We send junior faculty to those locales, hoping, of course, that they'll be released after a short stay. Very sad, of course, not to have, so very delighted to have Geoffrey Hoffman from the University of Michigan as a virtual visitor. Very sad that we weren't able to fill him filled with cheesesteaks last night. But just to let you know who Geoffrey is. So Geoffrey comes to us, as mentioned, from the University of Michigan, where he is an assistant professor of nursing. Geoffrey is a sparkling academic CV. He began college at the University of California at Berkeley, quickly realized that Berkeley has no student housing. You may have seen that in the news. And because student housing apparently is important, found that transfer to Harvard would make better sense. Harvard, of course, does have student housing. Graduated from Harvard in 1994. Moved back to the West Coast as quickly as possible. Eventually got his master's in public health from UCLA, and then proceeded to get his Ph.D. in health policy and management, also from UCLA. Because Ann Arbor is where all good people go when they are good enough. Ann Arbor recruited him in 2015 as a postdoctoral scholar, where he was a postdoc at the School of Nursing at Michigan until 2017. And then he joined Michigan's faculty as a tenure track assistant professor just about 5 years ago. Jeff's work is funded by the All Service Association, by a variety of other prestigious funders, including AHRQ, and the NIH. And so we are very pleased, Jeff, to have you here. Our habit at these events is to interrupt the speaker ad libitum, really almost without regard to where you are in your talk. So I hope you're ready for that. But we really look forward to hearing you speak. And again, thank you for joining us.
Thank you so much, Pete. That was the best introduction I've ever heard. And I would rather be a hostage nowhere else but here. So thank you guys for having me. It's an absolute privilege. I love being part of IHPI. This program is such a wonderful experience. These sort of transfers of scholars between the programs. For me personally, there are a lot of scholars here who study areas of great interest to me. So I just really wholeheartedly thank you for this opportunity and such hospitality despite our virtual connection. With that, I'd like to jump into the talk for today. So what I'll be talking about are the talk is titled Implications of Medicare Policy for Older Adult Functioning and Care. So basically, I'm going to be discussing two topics that are of great interest to me, which are fall injuries and caregiving in the context, perhaps a little unusual in the context of Medicare policy. I think no one here needs reminding that fall injuries and caregiving are quite commonplace in the older adult and aging US population. And they both have important implications for different reasons for the independence, the ability to stay on one's own in the community as one ages. And then, of course, as people interested in policy, researchers interested in policy, we spend a lot of time thinking about all of these Medicare policies that might have impacts on patient outcomes and on spending. But what's of interest to me in studying these two topics in particular is that Medicare, and I say this a little bit carefully and hedge a bit, doesn't really prioritize falls. And when I say falls prevention specifically, it doesn't really do a tremendous job of that. There's no specific falls benefit or caregiving really. When it comes to policy and caregiving, we're much more talking in the realm of the Medicaid policy. And so why I'm interested in studying these topics is that I do think there's some potentially interesting consequences for policies that may not be intended or known about, given that these aren't necessarily policy priorities when it comes to Medicare policy. So that's what I'll be talking about today. So as a brief overview or outline of what I'll be discussing, I'm going to talk about both falls and caregiving in the context of policy. I'll introduce the topic of falls briefly, and then talk about a first study that I've been working on, which addresses a particular policy, which is star ratings and home health quality and its relationship to falls. And then an introduction to caregiving, and a second study on whether entry or eligibility for entry into Medicare is associated with caregiving receipt. And then I'll just spend a couple of minutes at the end, if there's time, to talk a little bit about some other avenues and areas of research along the same lines of policy in these topics. So first, a quick introduction to falls. I think we're all probably experts and have great experience with tripping, slipping, or stumbling, whether it's over a carpet or a slippery sidewalk. And we probably all have either fallen or know someone who's fallen. You know, falls are really common. It's a question of when and not if, not to be overly dramatic. Not all falls are bad falls, but a lot of falls occur each year. We know from extensive research in this area that about a third of older Americans who live in the community fall each year. That's a lot. And, you know, the consequences can range from sort of a nothing burger to, you know, a slight sprain or strain or no injury whatsoever, to some more moderate or severe injuries that can include things like head injuries, hip fractures, things that can have serious ramifications for individuals' independence. We do know that for these reasons that fall injuries, when it comes to injury-related care, they are the #1 cause of emergency department and hospital admissions when it comes to injuries. They're also one of the leading causes of hospital admission overall for older Americans. I think one of the reasons why these are such high risk factors around acute treatments is that falls commonly occur right around the hospitalization. And whether this is because they are signal indicators of some underlying dysfunction or disablement, or they just are things that require a lot of care, we happen to see a lot of them right around a hospitalization. This is from some prior work that we've done. If you look in the middle where hospitalization is indicated in blue, we see that something that's been shown before, that a lot of falls occur right after the discharge from a hospital stay, but you also see a ramping up or a spike in risk in the month prior to the hospital stay. And in this study, we showed that the hospitalizations were not in fact due to fall injuries themselves. These were fall injuries that occurred that did not cause the hospitalization. So that this is really a critical juncture, these acute hospitalizations in the post-acute period when it comes to fall risk. And moreover, because of the nature of fall risk, we see that falls entail costly utilization. So about $20 to $50 billion annually is spent in the Medicare program on fall injuries for about $4.5 million older adults. It's a pretty big range there, but estimates vary across studies and how we estimate those costs. And finally, falls are a leading factor for loss of independence or institutionalization. So knowing these facts, it's of interest to get a feel for a pulse on what's going on right now when it comes to fall injuries in the country. So a few more facts. Fall injury rates are continuing to increase. There's a lot of geographic variation in falls. I'll show a picture in a moment. And falls also, as I mentioned, really happen a lot in these critical junctures around acute treatment. They happen to be a leading diagnosis for readmission. So in data from 2016 to 2019, we see that annual increases, age-adjusted increases in fall injury rates are about 1.5%. Over that 4-year period, then that's about 100,000 new fall injuries. So we see growth in year-over-year fall injury rates. We also see a lot of geographic variation that's about twofold, not quite. So in the central and plains states, there are quite high fall injury rates, and then you have lower rates in other areas, which raise a lot of interesting questions. When we see geographic variability, I think we instinctively think there might be something modifiable to address that is going on in some places that's not going on in other places. And finally, to hammer home the point that fall injuries really are most at risk around an acute hospitalization. We've done some work showing that fall injuries are a leading diagnosis at readmission. So they're actually the third leading readmission diagnosis overall after septicemia and heart failure. And for higher risk groups, those with a prior FRI and with cognitive impairment, they're the second leading readmission diagnosis. Okay, so we know that a lot of falls happen. They can be really injurious. They're costly. We also, because of these reasons, they've been studied a lot. And so we know some of the risk factors for falls. So you probably already know a lot of this, but to rehash, there are basically three categories of risk that we think about with fall injuries, sort of within body factors or intrinsic ones, things about your gait and balance and whether you have sensory impairment, your mobility. Extra individual or environmental factors outside the body. So these could be safety factors in your home. Is your home well lit? Does it have grab bars? Are the stairs safe to use? Do you have non-slip surfaces in your shower? And then treatment-related factors or iatrogenic ones. And when we think about trying to prevent falls, what we really think about is the interaction of these things, in particular the first two. And this will come into play in the study that I'll talk about in a minute. But what we're really interested in is even if you have some intrinsic capacity limitations, if you manage the environment well, you can still operate safely in there and avoid falls. On the other hand, regardless of how well you manage the environment, if you're not helping someone manage some of their intrinsic capacity, you could still be at risk for falls. All of which to say is that falls, despite their increasing nature over time and their worrisome outcomes, they are relatively preventable. There are a lot of interventions that have been shown to be so. These can involve community or home-based exercise programs. Some of them are listed here. Some safety modifications within the home that can be preventative, and then some clinical interventions, and then multifactorial interventions, which combine some of these different programs. And lastly, just to set up falls for a topic for the study I'll present, there's been a broad educational campaign by the CDC called the STEADY campaign, where a lot of effort's been put into educating not only providers, but patients and caregivers on risk assessment, personalized risk assessment, and tips for staying independent. To go ahead and prevent falls then, sort of summarizing everything I've discussed so far, it seems important to target these critical junctures where fall risks are highest. And because falls really occur across the continuum and it's hard to collect the types of care needed to prevent falls if you're on your own in a healthcare system that doesn't have a falls benefit, it's sort of important to provide sort of a one-stop prevention shopping opportunity. So there are policy opportunities to address falls, a lot of programs that address provider behaviors at these critical junctures. These are areas during a hospitalization or during a home health stay where these multifactorial prevention efforts could be provided. You could provide home safety tips if you're a home health agency, having someone visit the house. You could provide referrals for occupational or physical therapy if someone's in the hospital for a fall. You can also address their gait, mobility, and other intrinsic risks. So for these reasons, I think there are policy opportunities, even though they're not explicit. There's no explicit falls benefit. There are implicit opportunities to address older adult fall risks in Medicare policy. That said, it's not clear to me that policymakers and policy evaluators are seriously contemplating falls to the degree that maybe they warrant, given the high prevalence and high morbidity and mortality costs. And I don't believe from the literature I've seen, when you look at evaluations of bundled payments and readmissions programs and accountable care organizations, that they are commonly evaluated as a policy relevant outcome. So with that said, I'm going to introduce the first study, which is home health quality in falls. So why study this topic? Home health is a post-acute care setting that I'm characterizing here as a critical juncture. It's a very high-risk period after the hospital discharge.
Jeff, can I interrupt just because we do have a question in the chat? So Mark Pauley asks, are there also behavioral risk factors? I choose to engage in behaviors that increase my fall risk, written by someone who fell from a ladder. Beyond telling Mark not to climb ladders, what are behavioral aspects that you would consider in your thinking here?
This is a great question. One of the challenges when evaluating fall risk is to try to think about it as a product of two factors. One is sort of these intrinsic or environmental risks that may be quite high, but then multiplied by the opportunities for risk, so health behaviors. So, on the one hand, we typically think of, healthy behaviors like, regular physical activity or doing mobility and strength training as really positive. It's quite interesting to note that what I didn't show in that huge list of exercise interventions that have been shown to prevent falls, walking programs typically don't reduce fall risk. And I think a possible explanation for that is the more opportunities you have for falls, even if creating more opportunities for falls is a net positive, it improves your health, it improves upon these potential risk factors for falls, you still on the margins may have more falls. So
you need to increase people's sedentary behavior, right? That would reduce their fall risk.
That's exactly right. And so we do worry about, for instance, I haven't studied this, but I do worry about well-intentioned policies like sentinel events in the hospital, which Medicare no longer pays for, especially if it increases the severity of the coded diagnosis. Hospitals may potentially resort to chemical restraints, if you will. You're not allowed to use physical restraints, but keeping people more immobilized and not moving around rather than reconditioning them during the hospital stay, that might actually reduce falls when in fact, better care might be physical and occupational therapists coming in and helping people move around at the expense of a marginal, extra fall. So the behavioral thing is a really interesting aspect that's hard to study, particularly since we're looking at claims data where those data are not available. I will just say, jumping way ahead, I showed that slide on geographic variability of fall risk, and we've done some preliminary work looking at climate data and falls. And to steal that slide's information right now, we saw that with increases in temperature after controlling for weather patterns like rainfall, there are increases in fall injury risk, which is suggestive of just what we're saying. If you make people less sedentary, you might have more falls. That was very long-winded. I apologize. I hope that answered Dr. Polly's question. Okay, I'll continue on. So home health, I think, is an area ripe for study for falls, given this is when individuals might be at high risk for falls. It might be an opportune time to address these sort of fall risks that we've been talking about. And, I'm not sure if you'll buy this, but I would argue that it might be a little bit of a one-stop shopping-ish environment where a home health aide could look at the house and see if there's clutter, make an evaluation, help clean up with that, as well as help with physical therapy or occupational therapy or what have you. We know that home health is really common after hospitalizations. About a fifth of older adults are discharged there. They do commonly provide things that could be useful for influencing function and fall risks, e.g., occupational therapy. And it could also be an environment where they could help the patient work on those two interacted risks, conceptualized risk factors of intrinsic environmental risks. Okay, so here's the policy. CMS has, as we all know, introduced star ratings for a number of treatment settings. So there's hospital compare, there's nursing home compare. Well, there are also home health star ratings. These were introduced in July of 2015, and they basically tied payments from Medicare to agencies' performance on these star ratings. So the agencies were rated according to their quality, which was 0 to 5 stars. And so the purpose was really twofold. It was to measure and then reimburse high quality care on things like patient's functional improvement during the home health episode and acute hospitalization avoidance. but it was also supposed to be a transparent way to communicate important information to consumers. So a consumer could have an easy to use piece of information, i.e. a single star rating, single number that they could evaluate when deciding with family members where they might obtain post-acute care. There's some evidence that in this particular program that home health ratings, the star ratings, are associated with improved outcomes. For instance, slight reductions in mortality and use of healthcare services. Okay, so there've also, as with any pay-for-performance program, been some issues noted with this program. So I'll just list these really quickly. It's, on the one hand, convenient to a consumer just to have a single number. On the other hand, it's just a single number. And it may be that holistically, this just does encompass things that are important for the consumer, but it may also be that collapsing everything into a single number doesn't cover the particular priorities that individual patients might be interested in. A second potential issue with these star ratings is that data are collected and self-reported by agencies. And I think we've all seen, whether it's policies, arcane policies like the wage index, or other things where it could be endogenous, where you have an incentive to report your own information that's used to evaluate your quality. It may not be correct. We've seen this with nursing facilities. In fact, in the context of falls, reporting very low fall rates, but then when one compares that to the claims data, they don't really match up. A third issue quickly are lags in data. We're typically using data from the prior fiscal year, such as acute hospitalization data. So it's not clear whether the information are timely enough to indicate whether you'll get the same quality care when you go in. And then another one is just sort of these differences in the types of patients or the patient composition at different home health agencies. It's hard to know whether a high star rating for one agency may reflect better quality care and or they have a different patient population than lower rated star agencies. Okay, so thinking about these star ratings in the context of falls, we just sort of noted these issues, that it's hard to measure overall quality with a single number. And, maybe the single number, even though it's easier for a consumer to evaluate, it might have the wrong focus for that particular consumer. It may also be that this overview headline number doesn't reflect, a key measure critical for the consumer, like a fall injury. Maybe they're really interested in function, but that's not what policymakers evaluate as the most important outcome. Maybe they evaluate a readmission as the most important one, but that's not what family members consider to be the driving factor when they're picking a home health agency. So my sort of hypothesis here is that falls might not be reflective of the overall single quality measure. And then, of course, in evaluating this, we know that there are these compositional effects, these potential selection effects. So I just tried to illustrate that here really quickly. You could have higher risk patients at higher rated agencies or higher risk patients at lower rated agencies that could drive differences in, or sort of biased estimates of who's doing better. And that can occur if we have an inadequate measure of patient risk. Okay, so we conducted a study where we used 20% fee-for-service Medicare data. And we looked at older, recently hospitalized patients or those with a surgical procedure who received home health care from early 2016 through the end of 2018. And you had to have continuous fee-for-service coverage, no Part C coverage from the start of the home health episode going out 2 months. We used these star ratings that CMS uses, as I said, to evaluate these agencies. They are created each quarter, and we decided to use these quarterly star ratings to get the most up-to-date information. We looked overall at everyone who met our eligibility criteria, but we also looked by cohort, and we had 5 of them. You can see those listed here. The reason that we used these groupings was thinking that it may be that certain of these groups are quote unquote more targeted for things that are related to function and fall injury risk than others of those groups. So one might hypothesize, for instance, that if you have an orthopedic injury and you come in after, surgery on a lower joint extremity, or you had, some sort of fracture due to a fall and you come into home health, they may target you more than they would target someone who came in with septicemia or for rehab or what have you. So the fall-related injury, or FRI, I'll use for short, was our primary outcome. We've developed an algorithm with ICD-9 data that we validated using the health and retirement study, and then we've updated that algorithm for ICD-10 to identify fall injury episodes, and I can discuss those later if of interest. Harkening back to the slide I showed where there's high risk for fall injuries immediately after a hospital discharge, but then there's a precipitous decline. We decided to measure fall injuries at 7, 15, and 30-day increments after the hospital discharge. And these are explicitly and intended to be very different measures than what are used by the agencies. Some of the agency measures that are self-reported or evaluated by Medicare when developing star ratings involved claims data, but those are lagged, as I said. Then we also evaluated the sort of more typical measures. So 30-day readmission, that's 30 days from the hospital discharge going forward, as well as one that's used in the star rating program, which is any acute hospitalization within 30 days of the start of the home health episode. And we did this because falls might not be the right quality measure. It could be that, you know, the stars perfectly capture things that I think Medicare was thinking about when they thought what quality means, which are readmissions and hospitalizations, and don't capture things that families may value, which are falls. So we use some instruments that have been used, including by individuals at your institution very successfully to account for these patient compositional differences at agencies. So we use differential distance instruments, and this probably doesn't need to show this audience, but this is our instrument here on the left, which is proxying for agency quality. So we used a couple instruments. The first was a binary indicator where 0 measured an individual zip code as measured in the denominator file, was closer to a lower rated than a higher rated agency or equidistant. And a value of 1 meant they were closer to a higher rated compared to a lower rated agency. We used a second instrument for the acute hospitalization outcome. And we did this because we wanted to see what the shortest distance was to the agency with a minimum versus the maximum number of hospitalizations, to have an instrument more closely tailored to this specific outcome. We performed a 2-stage least squares analysis with zip code fixed effects. We adjusted for a number of patient factors, as well as prior utilization in the prior half year before the home health episode began, and then some time varying area factors that might be implicated in the outcomes that we were studying. So in terms of our analysis, we evaluated everyone who was eligible according to our criteria to begin, and then we did stratified by the 5 cohorts that we listed. We then implemented the 2-stage least squares analysis using that second instrument. And finally, just as a sensitivity analysis, we looked at counties with smaller gaps in their star rating gap. So if an individual was in a county where the difference between the highest and the lowest rated agency maybe was only 1 star, that might not make enough of a difference to move the needle in the outcomes. So then we compared those smaller gap counties to larger gap counties. So we did that as well. So as far as our output, first looking at our fall-related injury outcomes, the FRIs, we had about 71,000 in our sample. And here are our results. So basically we had null overall effects on fall-related injuries. Arguably, they were in the right direction, at least for the shorter term falls, for the 7-day falls. So that meant if you were in a higher rated agency with more stars, you had a percentage point fewer falls, if we trust the point estimates. That said, the sign clearly flips in the longer term for the 15 and 30-day FRIs, and in fact may indicate worse 30-day outcomes if we trust the point estimates here for higher rated agencies, which actually feels counterintuitive. There's a lot of information on this slide. These are the results by the cohort, but I'll just preface this by saying the results generally hold in terms of the length of time from the hospital discharge to the FRI, the time window that we used. 7-day FRIs generally had mostly negative coefficients, but then when you got to 15 and 30-day, they were positive, they flipped. when you looked at a quote unquote non-targeted condition, one that we might hypothesize might not be targeted by a home health agency when treating a patient at the home, respiratory conditions, you see positive effects in all cases. When you look at the orthopedic cases that might be more targeted, as I've tried to argue, you see a negative sign for the short-term FRIs, and then much smaller coefficients, basically null effects for longer-term FRIs. You can also see that we're pretty underpowered here, arguably.
So this is going to bother all the economists when I ask this question, but your F statistic is large and the exclusion restrictions are met, and
oh yeah, I'm sorry.
I don't have a license to practice economics, but I learned how to ask questions like that to try to make myself fit in. So
I really appreciate the question, Pete, because I also play an economist on TV. I'm not formally an economist. So yeah, the F statistics were quite high. I apologize for not putting those in here for this audience. My data analyst is going to kill me for getting this wrong. I think it was well over 150 or maybe even 200. So apologies for not presenting that. Thank you. Okay, so even for our priority patients, the estimates were directionally against expectations are small. And then this was interesting when we ran the sensitivity analysis to look at whether we're maybe just not getting, looking at the correct counties that have big enough gaps in star ratings in our instruments. You can see that there were larger differences in stars within counties were in fact associated with larger effects, which is what one might expect. So you had all negative coefficients, or you had negative coefficients in counties with larger star rating gaps. And finally, when we use the second instrument, you can see that for the acute hospitalization outcome, you had negative associations for that measure for both of the instruments, although the effect looks arguably, the point estimate is smaller using the second instrument. So this means that if you looked up that specific measure on Home Health Compare where it said, this agency does really well on acute hospitalizations, when you actually go to that agency later on, you're not guaranteed to have necessarily better care as measured by avoiding a hospitalization. There's a small change, but not necessarily a huge one.
So Jeff, Sayun Kim, who's one of our econ graduate students, writes, could you please explain how the distance instrument works, even though the patients are not traveling to the home health agency? As we think about all the barriers to patient travel, is there truly a differential distance effect for the care to come to the patient? And it's sort of the reverse of what we usually think in regards to these kind of differential distances.
Yeah, that's a really great question, and I'm not sure I can answer that fully satisfactorily. There is some, and I believe there's someone who may be here who can answer that probably beautifully better than I can, but I'll give it a shot. There's a paper on this which suggests that even though we're using, it is sort of counterintuitive, right? Or the way you described it doesn't necessarily work in the way we usually think about it in terms of distance to a hospital that actually is a physical structure. Even though this could be like the business office zip code for the agency, there is evidence that I think in a medical care research and review paper that people do in fact go to the closest ones, even though the agency is coming to your house. So it works out that the aides that work at those agencies work closer to the house, that people use those, tend to use those closer agencies. So I'm happy to get back to that question some more and refer the questioner to that article afterwards, if that's helpful. I hope that was okay. Okay, so moving on. So as a summary of the results, basically we had null overall effects, but we did see that with more stars, at least in the point estimates, there were fewer falls, shorter term falls. That said, we didn't see any longer term effect on falls, even for these so-called priority patients, so orthopedic injuries, where you might expect that the home health agency would pay more heed to, functional issues, reconditioning, et cetera. We saw no results, or that the wrong signs could be due to the fact that we had smaller gaps between the best and worst agencies, that those gaps were not meaningfully different in some of the counties. So when we got rid of those counties and looked at the larger gap counties, we saw effects more in the expected direction for fall injury. We did see that the signs were in the right direction for readmissions and hospitalization, which is what the program promises. And that suggests that home health agencies are focusing arguably on what is measured rather than what I'll call, holistic long-term functioning and injury. In terms of the implications, it seems like overall these star effects on quality are likely small. They may be present. If, to the extent they exist, they're concentrated on what's measured, not broad-based improvement. And then my contention, whether I'm maybe overstating it a tad, is that outcomes that are important for consumers and families, long-term care things that the Medicare program doesn't really countenance, but are still important to families, even if we don't, measure them typically in the claims or evaluate them as policy outcomes. They don't seem to be as prioritized despite frequent falls in the post-acute setting, which I think is arguably worrisome. And then to Dr. Pauly's point, I do want to point out, it has to be said that results possibly could be influenced by unmeasured health behaviors to the extent that, if the findings really are the reverse of what was expected, to the extent that better home health agencies are getting their patients up and moving more, which is on net good for long-term functioning, but at the expense of some additional falls, that could have influenced our results. And that's just not something we figured out how to assess or evaluate in doing these evaluations. Are there any questions there, I guess, before I jump into the next section, or if not, I'll just keep rolling. Did you look into dose effects? That is a great question. We did not. This is as far as we've gotten thus far. So we weren't able to look at number of PT visits. So, we didn't evaluate specific procedural codes or anything to that extent. We also didn't get as far as we would have liked into different types of fall injuries. I think the severity would be quite interesting to see whether, I'm sure patients and families might countenance trade-offs that you get a few extra falls if they're contusions and sprains, as if you can avoid, big, terrible fall injuries that really curtail independence. So those are things that we'd like to consider moving forward. Okay. Okay, so that was the first study thinking about policy, context, and falls. And now I'd like to introduce the second topic of this talk, which is caregiving in the context of Medicare policy. So a few words on caregiving to begin. I know we have some experts as well in the room. I was able to speak with Norma Coe earlier, who have great expertise in this area. We're probably also familiar, like we are with falls, people in our family. As we age, we need care support from family and friends. And arguably, this is a direct result that the Medicare program doesn't pay for long-term services and supports. And Medicaid will, but the eligibility criteria really restrict who's eligible to get some of that. And so family and friend caregiving is really widespread. So we know about 20 million Americans have nursing home level care needs, but they live at home in the community. About 6 to 8 million Americans receive family or friend, or what we often call informal care. Informal care may not be the right word. We say it as if it's just sort of informal and easy, but it often involves high levels of unskilled and increasingly skilled support. So I will use the word informal, but it's sort of becoming a word that we tend to avoid a little more these days. In terms of caregiving, the economics literature on it, we know that there's great interest in whether informal care can substitute or complement formal care, which will come into play in the study I'll present. And then there's just some studies suggesting that informal care remains unchanged or increases after hospitalization. I say this, I bring this point up because there's a massive literature on caregiving, and a lot of it tends to be about the stress process and caregiver burdens and things like that. But there's a lot less about sort of caregiving in the healthcare system in terms of empirical evaluations. So that's what we're interested in here. So as I say, there's tremendous literature on burden and employment costs and foregone labor and retirement and savings for individuals who provide care. There are also some important policy gaps for caregiving, as there were with falls, is my contention. So as I've said, there's limited explicit long-term care supports in the Medicare program. There are some state Medicaid-based waiver programs that support and actually pay for non-spousal caregivers in the family, cash and counseling and in-home supportive services in California. But generally speaking, we leave a lot of family and friend caregivers on their own to provide care, and they may be subject to whatever options are available in their local community based on area agencies on aging, but Medicare just doesn't really provide a lot of coverage here. So I think the last point I'd like to make about this is that, like falls, caregiving isn't typically evaluated in policy evaluations. So that sets up this current study, which is on Medicare entry and caregiving receipt. So just to visualize what we've discussed a lot previously, and people here know very well already, but after an acute hospitalization or surgery, a lot of individuals experience post-acute care, have a referral to skilled nursing or home health, after which many will either synchronously with post-acute care or continuing on afterwards will receive some informal care. But it may also be the case that after an acute hospitalization or surgery, one doesn't receive any post-acute care and just has a routine discharge to home and receives informal care for longer or shorter periods of time. So thinking about Medicare priorities as evidenced by what we spend dollars on in the Medicare program, we know that acute and post-acute care are where the bulk of spending occur. Surgical care is about $500 billion a year. Stroke care is quite expensive. And then we know that research focus tends to be on perhaps what we're most able to evaluate. And we use the claims data, and we can evaluate things like healthy days at home, preventable ED use, preventable hospitalizations and readmissions. Post-acute care is of increasing interest because we know there's a lot of variability in spending in post-acute care, and so potential opportunities for reductions in spend. And so we know about half of heart surgery or stroke patients use post-acute care, 90% of joint surgery patients do, lots of spending and variability. And those have been targeted, particularly in bundled payments for cost reductions. The informal care sector just has an equally large contribution, but is a little bit of a lower priority in policy discussions. I would contend some informal valuations of the societal costs of informal care is equivalent to what we spend on surgical care every year. So it raises questions on how do Medicare services affect informal care. And because we know that there are, let's call them inequities by gender in terms of who provides care, even though those gaps are somewhat shrinking. Women tend to provide more of informal care services. It's particularly interesting how Medicare policies may affect care by gender. So a few more facts to set up this study is that after major surgery, about 1/5 of older adults do need assistance with what we call for shorthand ADLs and IADLs, activities of daily living or instrumental activities of daily living. Prior work by University of Michigan researchers suggests that Medicare tends to be fairly generous with post-acute care. So they compared commercial insurance for individuals before age 65 to those who, through the age eligibility pathway, aged into Medicare, and saw really large spikes in spending on post-acute care compared to the commercially insured individuals. And then, as I said, we know caregiving is tremendously burdensome in multiple dimensions. We also know that some things that might factor into care received after surgeries in the context of Medicare policy are that many people wait until age 65 for some surgeries, like delayable cardiac surgeries and joint surgeries. And then from the economics literature, we know that decreases in Medicare payments for home health increase use of informal care for lower income patients. And that before retirement ages, spouses are the most common caregivers, but they provide less care if they're still working. So there are a lot of factors in play that might influence what happens around Medicare entry when it comes to surgeries and caregiving. That said, what we don't know is that there's limited focus on really not a lot of literature on what happens with informal caregiving after surgery. There's some small papers, but when you think of this massive caregiving literature, there's just really not that much in this area. There's a lot on dementia caregivers and caregiving, cancer, other long-term services and supports for other conditions, but not really surgery. So we also don't know, does more generous Medicare coverage of post-acute services help relieve or substitute for family caregiving after an acute hospitalization or surgery? So we asked the research question, what is the effect of Medicare eligibility and service on informal care? We looked at 3 conditions that have some interesting different dimensions. So stroke, which is unplanned, obviously, cardiac surgery, which is semi-elective, and joint surgery, which is elective. We asked whether Medicare coverage substitutes for informal care as measured by a decrease in the amount of weekly care received from family and friend caregivers or informal care, as well as where there was variation across our 3 conditions and by gender. We used the Health and Retirement Study, which is based here at the University of Michigan. I'm sure many of you might be familiar. It's longitudinal. The surveys occur approximately every 2 years. About 20,000 individuals are surveyed each wave. The survey questions measure about a 2-year period. So questions are asked about the prior 2 years. It's nationally representative, includes a really comprehensive set of caregiving measures that are reported by the care recipient or a proxy informant. And we used data from 1998 to 2018. Our study population included individuals 59 to 74 with 1 or more limitations in ADLs or IADLs. If you're curious why we chose those criteria, in the HRS, the individuals who are asked caregiving questions are only those who have at least 1 ADL or IADL limitation. So we made the judgment call that we would restrict to that population. Our primary outcome was weekly informal, i.e. unpaid family and friend caregiving hours. I'll talk a little more about that in a couple of seconds. This caregiving, as measured, defined in the HRS, involves help with these ADLs and IADLs. So ADLs would be some of the things you see here: eating, bathing, toileting, dressing. And IADLs would incorporate things like managing money, using the telephone, grocery shopping, and making meals. In terms of our cohort definition, we have these 3 cohorts as mentioned. Certain individuals may have had more than one of these events per wave. So if so, we assign them by acuity. So if they had a stroke and joint surgery, we assign them to the stroke cohort. If participants experienced, say, 2 cardiac surgeries in one wave, we allow them to contribute multiple observations. So the age eligibility pathway into Medicare, I think, is fairly well known. Is at age 65, individuals are eligible for Part A and Part B coverage. That said, given that there is a approximately 2-year look back in the HRS, so questions are asked in the past 2 years, did you have a stroke? In the past 2 years, did you have cardiac surgery? To be as conservative as possible, we had a pre-eligibility cohort that ranged from ages 59 to 66, and a post-eligibility cohort from ages 67 to 74. And in this way, because some of the individuals shown here in blue might have had a surgery after Medicare injury, we might have noisier estimates, and hopefully they should be in the conservative direction, but people might have questions. We evaluated the 2 cohorts in order to try to make them balanced on all covariates. We matched the cohorts. We also are interested in evaluating them without matching, but this is what we chose to do. In evaluating caregiving, we measured it in 3 separate ways. We looked at the overall amount of weekly care received. We looked at the percent using any informal care. And then we looked at the quote unquote intensity of care, which is the weekly hours of care received amongst those receiving any care. So if you multiply 2 and 3 together, that would give you the overall average weekly hours. We used a regression discontinuity design, which provides the instantaneous change in caregiving use at Medicare entry. And we used a linear interaction of a Medicare dummy variable with a centered age variable. We performed a number of what we believe to be best practices following the literature, so sensitivity analyses, exploring the use of alternative model specifications, a shorter range around entry in terms of the study subjects' ages. We removed potential outlier data you'll see in the data at age 73, and then we did some of the diagnostic testing to make sure an RD analysis was appropriate. In terms of our results, we ended up with a sample of approximately 2,300 participants, evenly matched between pre and post Medicare. About 60% were female in both cohorts, 60% married, and baseline limitation numbers of ADL and IDLs measured with a range of 0 to 5 are shown here of 1.8 and 1.4, which are pretty high. And then most of our cohorts, most of our sample, about 3/4 was stroke, joint was 16%, and cardiac surgery 11%. In terms of who the caregivers were, you can see that that spouses represented the greatest population of family caregivers. They represent about 50% overall. You also see that other relatives were the next highest. So that would be children and siblings, and then friends, non-relatives in purple here. And you can see that there were differences by a cohort, with stroke being the greatest amount of care. So overall, there was an average of 20 hours per week of care received. Again, I'll remind you, these numbers are for individuals who had a quote unquote disability, like one or more ADLs or IADLs. So it's a little more high acuity population than you would see if we didn't put those constraints on our eligibility criteria. About 53% received any informal care. That was pretty evenly split between males and females. And the care intensity, that is the number of hours per week received by those getting any care, was 37.4. And that was pretty similar across gender. In terms of the regression discontinuity findings, the estimated, so the average hours overall of care received at Medicare entry was 21.8 hours, and there was a discontinuity, so a decrease of 6.4 hours per week at Medicare entry. In terms of the probability of any care receipt, there was a very large 14.9 percentage point drop from a baseline of 61% at Medicare entry. Care intensity, we did not see any change. There was, so amongst those still receiving any care, so the number receiving any care decreased, but amongst those receiving care, there was a very small change. Now looking by gender, you can see that for men here, nothing rose to the level of significance, but there were big probability decreases and similar overall care decreases to the total sample. For women, pretty similar numbers, larger probability decreases for women. And again, I'll remind that 60% of the sample were women. In terms of the cohorts for stroke, this is where we saw, quote unquote, the biggest effects if we evaluate that using the p-values and the point estimates. The probability decrease was 13.6, p-value of 0.003. For heart, we saw, for cardiac surgeries, we saw even larger numbers, but they did not rise to the level of statistical significance. And for joint surgery, there were small effects. So to summarize, care intensity in our sample of 37 hours per week is nearly a full-time job. We haven't seen a lot of research on the intensity of care received after these types of acute events, including surgeries. And so we think this is an addition to the literature, thinking that, you know, the caregiving after some of these things are nearly as common and intense as for other conditions that are often measured in the literature in caregiving. There were some notable changes at Medicare entry. So there was a 25% decrease in the probability of use, a 29% decrease in the average number of care hours received overall, and some arguably small differences by gender. So we saw decreases for women, but not for men in the probability of any use. And then most of the effects were observed for stroke, but not the other cohorts. That said, there were large negative point estimates for cardiac surgery. Okay, so in context, we think this is new and interesting information that post-acute care under Medicare may substitute for some informal care. This has some potential implications for gender equity, given that women tend to provide the most care. So entry into Medicare might relieve caregiving burdens for individuals, but it does raise questions about informal care use in the context of these newer alternative pay models that reduce post-acute care use. And so we know that bundled payments are trying to reduce the use of post-acute care and save money, but we wonder if that is having some sort of spillovers and sort of drawing money from the savings of informal caregivers, if you will, sort of putting the care needs on the backs of informal caregivers. So overall, drops in the probability of use and the amount of care. These are full-time jobs for caregivers. So Medicare might be diminishing some of these burdens. And so going back on that might be really problematic. In the interest of time, I'll just go through the rest of this quickly. Some new work we're doing. So I mentioned this slide, a lot of geographic variability. So we're interested in environmental factors, things like weather or physical activity that might be influencing these differences. So we've done some preliminary work on weather, showing, as I mentioned, that temperature increases are leading to injury increases, which is suggestive of health behaviors influencing things. We're also looking at the implementation of the readmissions reduction program on fall injury risk, which we think is important given that injuries are a big leading diagnosis for readmissions. And we're also looking at falls in the context of COVID-19, given that we've done some work showing big changes in mobility and conditioning already early on in the pandemic. And then finally, we're looking at Medicaid expansion and caregiving. So I apologize for rushing for the last few slides, but I think I used my time, a little too much of my time. So I'd just like to thank my wonderful co-authors and then open up for any questions.
So Jeff, that was fantastic. Maybe I'll take the prerogative. And so it feels like you picked stroke, cardiac surgery, and joint replacement, but it feels like those are sort of quite different animals. And something like stroke, not always, but sometimes you know, severe deficits that are persistent, right? That patients will then need considerable at-home care for the rest of their lives. Whereas cardiac surgery and orthopedic surgery are often done to enhance the ability of patients to perform ADLs, right? You imagine a certain post-operative period of recovery, but then no further need for or limited further need for at-home help. So I wonder if that, and you probably thought of that already. So I guess I wonder how you think these results from a policy perspective. I mean, if I know my mom only needs help for like 6 weeks after her hip replacement, that's a big difference than my mom is now paralyzed on her right side and needs help forever. So what do you think?
Yeah, I mean, I think the way you explained it is how we were thinking of it, and you said it better than I could. I mean, I think our aim was to include conditions where you might not expect, I didn't perhaps set this up quite, but you might not expect with joint surgery, which really doesn't entail a lot of caregiving altogether. And that's a gross generalization. My dad just had shoulder surgery and it's been a lot of rehab and very painful. But I think we weren't expecting arguably to see like big changes in joint surgery, particularly given that we have this 2-year window. I mean, I think some of the constraints on the study is the HRS, has this 2-year window. So it's really hard to know what happens in that first period where all of the stuff is really happening. So I think to your point, seeing changes, even looking at this broad period that entry into Medicare has on stroke for something that has continuing long-term consequences for functional diminishment and needs from, supportive family members, is pretty impressive, because you might see the biggest changes really up close. And something we weren't able to do just because sample is pretty constrained is try to evaluate stuff just within a few months of surgery. A, because we couldn't really measure exactly when the surgery happened, and B, because you can kind of guesstimate when the caregiving's happening because the questions ask about the prior month, the care received in the prior month. But, and then we thought of linking to the claims data to actually identify the surgery, but then you just really start shrinking the sample. But to your point, I mean, I think from a policy lens, if we're thinking about like extracting dollars from post-acute care, they're going to go to places like stroke that are the most expensive to try to generate some savings potentially. And I'm not as familiar with BPCI as maybe I should be, and where those savings have occurred. I can't remember if it's mostly medical or surgical conditions, but if we're extracting money after something like stroke, if we find any of what I presented somewhat credible, then, arguably that's problematic. So from a policy lens, you might try to build into your policy an evaluation that's well-intentioned, that targets spending and outcomes, but not just look at, readmissions as your outcome. You might incorporate, I don't know how you would do that if you're Medicare or your CMS, but somehow try to also incorporate what we're talking about, things that are valued by the family. I know like Medicare has the current beneficiary survey where they ask patients and families, and you have HCAHPS. Maybe we should be incorporating more of those things when we evaluate BPCI, I guess, would be my big bloviated response to your question, Pete. I don't know if that's practicable, but I think that would be worthwhile, is kind of what I'm trying to push at here is, think about things that family members maybe care about too. Anyway.
I'll take bloviated responses. That's just fine. So we're actually a little bit past the time, but Jeff, thank you so much for really expounding on excellent work. I feel more educated. I think the group, which is largely on Zoom, but is very much engaged in very similar issues, has very much appreciated your talk. So again, thank you for your visit. Best of luck in your continued work, and we look forward to seeing you in person at some point here soon.
I couldn't thank you guys enough. I'm so just above the moon to be with you. Thank you, Pete, for your generosity. Thank you, guys.
See ya.
Bye.